Switching gears, thank you for all the hip docs. Now we're going to switch to the knee, and it's a great pleasure for me to introduce our newest colleague and partner at CU Sports Medicine, Dr. Rachel Frank. She has spent the past year training with Dr. Cole, and who you're going to hear from later, and all the great surgeons at Rush. She is a former collegiate soccer player, has a great interest in the knee and articular cartilage, and be heading up with Dr. Verdal, our articular cartilage and knee restoration program at the university. And as any young faculty get to do, the young faculty get to do the anatomy and exam of the knee. So Rachel, come on up and give us some of that.
All right, well, thank you, everyone. Thank you, Dr. McCarty, for inviting me to give this talk. And I'd like to thank you all for coming. This is obviously a tremendous event that seems to get better each year, and I'm very honored to be a part of it for the first time this year. I have no personal disclosures. I would like to say that Jorge Chala, a physician who's now a fellow down in Kerlan-Jobe, donated a lot of his material with regard to arthroscopic and anatomic dissections and videos, and I'd like to acknowledge him for that. So here's a case that I just saw a couple weeks ago when I was visiting Al Getgood in London, Ontario, of a patient that had a significant injury to his knee after a motorcycle accident, had many other injuries, pelvis trauma, upper extremity trauma, head trauma, etc. But what we'll focus on is the knee because that's what we love the most. And as you can see here, nothing is stable. Everything is out. This is what's called an EFL, or in every effing ligament. And that's not my phrase. That I think that was coined by Rob Laprade. And so this is a bad situation for this patient. And for us as clinicians, it's important to understand what is broken and what needs to be fixed, to keep it simple. And so the concept when we talk about anatomy and physical examination, while sometimes it can be a dull topic, it's the key to what we do in orthopedics, whether you're a surgeon, you're a clinician, you're a therapist, or anything else in the field. The anatomy is the key, and it's really the functional anatomy. What is abnormal, what's not functioning properly, and what can we fix? The first part of anatomy and of physical exam is taking a good history, and I think we know that. If you don't ask the patient what happened, you're going to be going down a path that may be completely irrelevant, even if you see all of this interesting anatomy that might be quote-unquote wrong on a diagnostic imaging study. So talking to the patient, understanding why they're in your office and what the problem is the first step. And then performing a good physical examination together. By knowing your anatomy, looking at their history, and looking at their physical examination, you can usually come up with a diagnosis before you even look at any diagnostic imaging, and certainly before you go to the operating room. When we do a physical examination of the knee, some general pearls I think are as follows. You always want to look at alignment and gait. I think key things to look at in all athletes who are presenting for knee pathology includes quadricep strength as well as core strength. It's amazing how many athletes come in with knee pain and you ask them to stand on a single leg and perform a squat. Their knee goes into dynamic valgus. They have no control over their hip abductors. They have no control over their core, and that's really the main problem. And so we can avoid surgery and really avoid any issues with the knee itself and get rid of their knee pain if we really can figure out what's causing them to have abnormal mechanics. I think another important thing that's begun to get recent attention, particularly in the female athlete, but also in the male athlete, is looking at generalized ligamentous laxity. This is particularly important when we're considering partial ligament injuries in patients. What may be normal for that patient may not be normal for another patient, so it's always good to understand what their baseline collagen is like. Are they super loose, are they flexible, or are they not? One exam maneuver that I like to do a lot is asking the patient to point with one finger. I think when they come in and they say, I have knee pain, and you really ask them to just take their index finger and point to where it is on the knee, that can really help guide the rest of your physical examination. And then certainly it's important to look for acute injury signs, effusions, ecchymosis, dimple signs, locked knees. Those can often tell you what the problem is even before you've touched the patient. And certainly you're always comparing to the other side. The general order of steps for the physical examination that I've become accustomed to doing, at least in my training thus far, is having the patient stand, watching their gait and alignment. Then I have them seated and I check out their patellofemoral joint, and then I get them supine on the examination table. And I try not to repeat steps for, number one, the sake of efficiency, and number two, especially if they have an injury, I want them to move as little as possible so that they're not having any problems. After I do my inspection with all the things that you see here, I look at range of motion, I check their extensor mechanism all the way throughout. Stability testing comes next, and then finally palpation exam, because that's usually the most irritating for patients. Now certainly this can be adjusted pending the pathology and pending the patient. If they come in with a classic history for, say, example, an ACL injury, you don't need to do every single test in the book for the knee when you're really focused on the ACL, but you should do a systematic approach to your exam for every patient every time so that you don't miss anything. Also, we have to keep in mind, before we get to the crux of the talk, which is on knee anatomy, there's a lot of things outside the knee joint that can certainly mimic intra-articular knee pathology, and these are some of them. Pes bursitis, I think, is something that I didn't recognize early on in my training as much as I should have. These are patients who come in with raging medial-sided knee pain. They really are inflamed. They might not be super erythematous or warm, but they have pain right over the pes, and it can sometimes mimic an MCL injury or mimic medial joint line pain in the setting of a suspected meniscus tear. So it's important to look for pes bursitis, and then other extra-articular sources of pain that you see here, such as IT band tendinitis, quadriceps weakness, which will cause patellar maltracking, which will cause anterior knee pain, hamstring tightness, which can certainly cause anterior knee pain, particularly in our male athletes, and certainly radiating pain from the hip or spine. So we'll go into looking at bony anatomy and alignment. So first things first, we have to look at the alignment of the patient. The normal alignment of the knee is 7 degrees of valgus, and the medial compartment of the knee sees approximately 60% of load while we're weight bearing, and that's at normal, but not everyone's normal, and so some patients have a more varus alignment where more weight is going through the medial compartment, and some people have a valgus alignment. And these are important things to consider, especially when we're doing surgical planning. The next thing I look for in the physical exam with regard to bony alignment and overall alignment is the Q angle. Now, we all know in females the Q angle is typically wider than it is in males, but the general range is about 11 degrees plus or minus 7 degrees. This can be increased by femoral anteversion as well as external tibial torsion. And again, this is important to pay attention to, especially when we're considering procedures for the patellofemoral joint in case a realignment osteotomy might be needed. Another thing to pay attention to is we often look at Q angle with the patient either standing or supine on the examination table, but that's not how we function. We function by walking, squatting, etc. A lot of patients have anterior knee pain when they're going up or down stairs or when they're squatting or doing lunges. They may have a completely normal Q angle, but if we ask them to do that single leg squat in the examination room and then we see them shift into dynamic valgus, well, their Q angle all of a sudden increases. And so it's important to pay attention not just to the static Q angle, but also the dynamic Q angle. When looking at the patellofemoral joint in terms of anatomy, it's important to pay attention to the osseous congruency of both the patella and the trochlea. Patellofemoral contact begins at approximately 20 degrees of knee flexion, and by the time you get to 90 degrees, there's not much there. There's certainly many stabilizers, and this is a complex joint, which is why anterior knee pain can be so difficult to treat. But I think we're starting to recognize more and more that bony anatomy, and or in particular, abnormal bony anatomy, including trochlear dysplasia and abnormal morphology, is critical when we're talking to these patients, especially those with instability and recurrent instability. And then looking at the quadriceps muscle tone, the VMO is particularly important, and so it's incredibly of interest for us to really talk to the patients, measure their thigh girths, get side-to-side assessments, and see if there's something we can improve with regard to their dynamic and static stabilizers and try to avoid surgery in these patients with anterior knee pain. The general patellofemoral examination has you check, I check for hamstring tightness because that can lead to anterior knee pain, and that's something that we can easily remedy with a good therapy program. Crepitation, patellar tracking, and all the things that I previously mentioned throughout the last couple of slides. We'll move on now to talking about meniscus and articular cartilage anatomy. So the menisci, there's two in the knee, one on the inside, one on the outside. The medial meniscus is more or less immobile. It's semicircular or C-shaped. It covers half to 3/4 of the articular surface of the medial tibial plateau. And it's really immobile because its posterior horn attaches to the posterior intercondylar area of the tibia, just anterior to the PCL, and also has an attachment to the posterior medial capsule of the joint. When we look at the lateral meniscus, it's actually more mobile because it doesn't have that attachment, and it has a brief attachment to the capsule, but that's interrupted by the popliteus. And so this lateral meniscus is much more mobile. It covers much more of the articular surface, and this is why lateral meniscus tears and lateral meniscectomies, when a patient gets a quote-unquote simple scope, can be so problematic. Because if you lose some of your lateral meniscus, your body is used to having a lot of lateral meniscus to distribute load and cushion the articular surface of the tibia. And so when we lose that lateral meniscus, we often see patients shift into a disastrous situation even months or a year after their scope, where we don't really see that on the medial side. The medial side after meniscectomy, we see changes related to arthritis years or decades later, but on the lateral side, we're often seeing it much quicker, and it's because of the anatomy of the meniscus. These are some anatomical dissections, again from Jorge, showing the roots and showing the anatomy and their congruency and relationship relative to the cruciate ligaments. Key to the understanding of the meniscus is its blood supply. Its blood supply is from the peripheral third, as published by Arnosky several decades ago, and this hasn't changed, and this is why meniscus tears have very much troubled us, because they don't really heal unless it's that perfect tear pattern in the peripheral third of the meniscus. The other thing to keep in mind is the hoop stresses of the meniscus. So the collagen type 1 collagen travels longitudinally around the meniscus, as you can see in this schematic. And so even if you have a very small meniscus tear or meniscectomy, if it goes all the way through from front to back, that's equivalent to a total meniscectomy. Even if 3/4 of your meniscus is remaining. When you disrupt those hoop stresses, the meniscus no longer functions. So something to keep in mind. Meniscus examination, I think we're all very familiar with, so I'll breeze through this, but it's really, for me, effusions and joint line pain. I think some of the special tests, the McMurray's test, Thessaly test, those are helpful, but it's really their story, clicking, catching, locking, mechanical symptoms. Can they not perform a deep squat without a lot of pain? Is that pain posterior to the midline on the side that we're concerned about? I try not to rely on MRIs unless I'm really looking at ramp or root lesions, because I think MRIs can be tricky with regard to figuring out pathology in the meniscus, but it's really the patient's complaints of joint line pain with effusions. When we move on to the articular cartilage is comprised mainly of water in its extracellular matrix, type 2 collagen, as well as chondrocytes. The water content increases with osteoarthritis but decreases with normal aging, and really it has poor blood supply. Articular cartilage is aneural, it does not regenerate, and it's avascular. We have to be very careful when we're talking about biologic therapy and regenerative medicine, so to speak. Articular cartilage does not regenerate. When we do procedures such as chondroplasty or microfracture or any PICC procedures, we can get cartilage to come back, but it's not the same. It's fibrocartilage. It's not regenerative articular cartilage. I think newer technologies and something that's of interest, I know to our group here and many groups around the country, is figuring out what we can do to improve the biologic environment of the knee, and that applies also to the hip, shoulder, elbow, ankle, and any other joint to really help with a biologic augmentation to surgical procedures or non-surgical procedures. But we have to be careful when we think about the word regenerative, because to date, at least to my knowledge, there's nothing that regenerates type 2 hyaline articular cartilage. We'll skip through some of the nitty-gritties of the cartilage. One slide I did want to point out is cartilage pathology is very, very common. This is why, again, I don't necessarily like to rely on diagnostic imaging or even the scope. I really like to rely on the patient's physical examination and history. Where are they hurting? These 3 papers have shown that we see articular cartilage defects in nearly 2/3 of patients undergoing an arthroscopy. Certainly 2/3 of patients don't need an articular cartilage treatment, and they haven't had articular cartilage symptoms. The point is that these lesions are common, and so we have to use our clinician skills, our diagnostic skills, and our physical examination skills to determine which lesions are symptomatic. Do all cartilage lesions require treatment? I'm not so sure. So the rest of the talk is going to focus on the main ligaments of the knee, and I'm going to go through these slides fairly quickly. I'm happy to share them with anyone who's interested. A lot of it is the surgical minutia and the footprint details, the bundle details. And when preparing this talk and really thinking about knee anatomy, it's interesting. There's a lot of studies in the literature that talk about all these minute details. Where is the footprint on the femur, and where is it on the tibia, and where is it on the fibula? But then when you're in surgery and you're drilling, say, a 10-millimeter tunnel, if you put when we're in surgery, we're drilling this tunnel, you put a pin in first, maybe a 2-millimeter, 2.4-millimeter pin, but then you're going to drill out a 10-millimeter tunnel, and we're arguing in the literature about changing things by 1 millimeter to the next. But when you're reaming your tunnel, you're really it doesn't matter. So it's good to know the anatomy and understand these minute details, especially when you're doing studies, biomechanical studies. But I want to emphasize that a lot of these studies not necessarily helpful for us when it comes to surgery, other than telling us where the footprints should be. But so that's my rationale for skipping through some of these slides. So the ACL is the primary stabilizer to anterior translation in the knee. It's got 2 bundles, anteromedial, posterolateral. The posterolateral bundle is the most important one for rotatory instability, responsible for the pivot shift test. Its femoral and tibial attachments are as you see here. The lateral epicondylar ridge, or for the residents in the room, residence ridge. This is an important landmark that's always identifiable, always in the OR, whereas the bifurcate ridge, which is the ridge that separates the bundles, can be a little bit more difficult. If you put your tunnel anterior to the residence ridge, that's going to be a problem for the patient. So that's why we want to understand these landmarks, and there's some great dissection studies that really show these. And then the tibial attachment we can see, which is how the ACL is named for, really in close congruency to the anterior horns of the menisci, particularly the anterior horn lateral meniscus. ACL examination, certainly in the acute setting, can be limited by pain, guarding, bucket handle meniscus tears, et cetera. But typically the go-to examination maneuvers are the Lachman, the pivot shift, which is pathognomonic. Pivot shift sometimes can be difficult to do in a patient who's just had an injury. Lachman can be a little bit more reliable. And then historically and in some clinics around the country, the KT1000 test is still used. This is an example of the pivot shift. So the knee the tibia is currently anterior shifted, and as we flex up, it reduces back into place. Posterior cruciate ligament, primary stabilizer to posterior translation at 90 degrees. Again, 2 bundles. The anterolateral bundle is larger. The femoral attachment has 2 portions to it, right in the roof of the notch, and then posterolateral to the wall there, and then the tibial attachment is just about 1 centimeter behind the back of the tibia, and that can be one of the more challenging parts of the surgical procedure in terms of identifying that and staying right on the bone and making sure that you can see adequately to get your guide in there to drill your tunnel. Again, some nice anatomical dissections. Should be noted that about 90 degrees, the medial tibia sits about 1 centimeter anterior to the medial femoral condyle. So when we're doing a posterior drawer test or looking for a sag, if your tibia and your medial femoral tibia and medial tibial plateau are lined up, that patient probably has a grade 1 PCL injury because that tibia normally sits a little bit anterior to the medial femoral condyle. So a lot of clinicians, and I love this test, actually put their hands right on the patient like I'm doing here, and when their thumb IP joint moves just a touch, that's when you know you at least have a partial or grade 1 injury to the PCL, and it may be subtle. A lot of these injuries are subtle, and again, you always want to compare side to side. Some of the other tests, including stress x-rays, you can see here, which have shown to be very helpful for diagnosing what can be a difficult injury. The posterolateral corner is one of the more challenging parts to the knee. I know as a resident fellow, the anatomy is very difficult, especially in an acute situation when it's blown up, or even in a chronic reconstruction situation when it's all scarred down and you have to worry about that little structure of the peroneal nerve so that you don't have the patient leave with a foot drop after surgery. There's a lot of different structures. This has been really well delineated out in the literature, and we'll talk about a few. This is a nice video that Jorge put together really showing some of these structures: the lateral or fibular collateral ligament, the popliteal ligament, the popliteus tendon, and several other structures. There's about 10 structures in the knee, but these are the ones we really think about when we're doing surgical reconstructions. And we have to think about the fibular collateral ligament as being important for side-to-side laxity, whereas the remaining parts of the posterolateral corner being more important for rotatory stability. So again, these are the 3 main structures that we really worry about when we're reconstructing in surgery. Some more anatomic dissections. I'm going to put this slide up here. This is mainly for kind of the residents and fellows in the room. These questions are always asked not only in the operating room, but also on the in-training exam and on your board. So it's important to know your femoral and tibial attachments and fibular attachments for all of these structures, and which structure is anterior to which and which is posterior to which. This is another nice video from Jorge just showing the translation or rotation between the tib-fib joint, which is something else that we look at when we talk about patients with posterolateral corner injuries, and the different structures that are involved with stabilizing these patients. Posterolateral corner, that should say PLC examination. The posterolateral corner examination, number 1, check the nerve. I think as orthopedic surgeons, we get really excited about going to the ligaments. Check that nerve, document if it's in or out before surgery. You do not want to have that not documented before surgery, that they had numbness, paresthesias, or a foot drop, and then they come out of surgery and they have that, because all of a sudden then it's on you. So document what their examination is beforehand, and then some of the various tests that we have here. And here's an example of how many branches there are to the common peroneal nerve, and as it comes around in the fibular head, it's right in the way of where you're drilling your fibular tunnel. Again, let's just say PLC examination, so I apologize for that. Many more tests you can do. The dial test, I think we all know, looking at external rotation side to side, both in 30 and 90 degrees. Looking at the posterolateral drawer test, the reverse pivot shift, and then stress x-rays. If someone comes in with a varus or hyperextension thrust and they have a story suspicious for a PLC injury, you have to be really concerned about many ligaments being out. If they have that kind of thrust, that's a high-level injury, a lot of capsular disruption, likely going to have a neurovascular injury, up to 15% in those cases, and so you want to be really cautious with those patients. Finally, last but not least, we'll talk about medial knee anatomy. The medial knee is a little less complicated than the lateral side of the knee, but still a lot of structures to pay attention to. It's historically been described in layers, layer 1, 2, 3, but I think more recent anatomical studies really just talked about the structures. So the main structures that we care about bony-wise are the adductor tubercle and the medial epicondyle, and then we use those anatomic landmarks to actually feel them or see them in the OR when we're drilling our tunnels for, say, MCL reconstruction or medial patellofemoral ligament reconstruction. So the osseous anatomy is key. And again, a nice video showing the medial epicondyle here. You're going to see the medial collateral ligament superficial, the posterior oblique ligament, and then you'll see the MPFL coming in. So just a really nice way of kind of visualizing all the ligaments on the medial side of the knee and the anatomy involved. Superficial MCL is superficial, obviously, and then the deep MCL is really an adherence to the capsule. And finally, the posterior oblique ligament coming off the semimembranosus. There's an example of the deep MCL, and then that posterior oblique ligament, which has been described as having 3 arms. Again, for reconstruction purposes, I'm not so sure that that's extremely relevant, but something that we can look at anatomically. MCL complex examination is done with applying valgus stress, just like we do on the lateral side of the knee, applying varus stress, and then you can do the anterior medial drawer test as well. Last but not least, the MPFL, everyone's favorite. So the MPFL resists lateral translation of the patella, and it's really isometric between 0 and 90 degrees. Schottle's point has been well described on the femur as its attachment, and you really have to look at this. And again, for the residents and fellows in the room, this comes up every year on the in-training exam and on boards. So it's important to know these landmarks. And on the patellar side, the attachments between the proximal and middle thirds of the supremedial border of the patella. When we talk about MPFL, when we talk about physical examination, the videos, that's a really great video. I'm sorry, I don't know if we can get it to play. But we have to pay a lot of attention to not just the ligament status, which you'll see here is not there, but we also have to look at the bony morphology, the trochlea. Are there cartilage lesions? Does the patella need to be realigned? And so these are all considerations, and it really comes down to, again, the anatomy and the complaints. All right, so take-home points, and I apologize because I went a little bit over, but I'm hoping this provides a comprehensive approach. Knee anatomy is complex. All of the minutia, is it clinically relevant? I'm not sure. I think the biggest example of this is all the focus that was the rage on double bundle ACL reconstruction about a decade ago. That procedure is still being used, but it's not been shown to be any better or superior with regard to outcomes or failure rates, but it's a lot more challenging technically. It takes 2 drill tunnels in the femur, a little bit more morbid for the patient. Physical examination combined with history should drive your clinical and surgical decision-making, and then diagnostic imaging, which Dr. Major will talk to us about, will really augment our clinical decision-making. So together, you should really have a solid game plan for the OR before you ever get there. And then some of the things I mentioned before that I think are really key examination pearls can be helpful for us. This is just a picture for my fellowship with Dr. Cole. I'm not sure, I haven't seen him yet, but I just wanted to thank him for coming out here today and thank all of you for your attention.